Robert Wood Johnson University Hospital, Somerset. Thank you for joining our webinar on understanding the needs of the LGBTQIA community, presented in collaboration with Friends Health Connection. Our guests today are Jeremy Pyke, an advanced nurse practitioner, or advanced practice nurse with Robert Wood Johnson University Hospital, Somerset Proud Family Health, and Danielle King, patient navigator with Robert Wood Johnson University Hospital, Somerset's Proud Family Health. We will begin today's webinar with about 20 minutes of a moderated discussion. Then we will open it up to questions and answers from our audience. So first, welcome both of you. Thank you for joining us.
Thank you.
I'd like to start by asking you each to tell a little bit about yourselves and your roles at Proud Family Health. So Danielle, why don't we start with you?
Okay. So my name is Danielle. I went to Rutgers University and I got my master's in public health. All of my study, all of my research was all geared around LGBT healthcare. So I wanted to know more of why are we not going to the doctors? Why do we have such high determinants of health and different factors that play into that? So I came to Proud and I got the interview and I was very excited. And I felt like the role was very fitting for what I wanted to do in the community. So what I do in the community is I do a lot of education with different offices, either physician offices or community resources. I also do a lot of education with our own patients. A big part of what I do is if a patient is seeking some type of care that they can't find or they're uncomfortable finding, I always try to make sure that I reach out to our resources and know if they're LGBT friendly. But LGBT friendly can mean a wide range of things. So anyone can say they're LGBT friendly, but they don't actually have policies in place, or they don't have, they don't understand what are pronouns or how to use preferred names. So I ensure that all of our resources, no matter where they are, that they understand that, so that our patients, if we're referring them there, they're getting the same type of care that they would if they're with us.
Yeah, that's wonderful. Thank you. Jeremy, please, about yourself, if you wouldn't mind.
My name is Jeremy Pyke. I'm a nurse practitioner, and I've been a nurse practitioner for several years. My training, I went to the College of New Jersey, and my graduate studies were focused on trans health, and I really focused on primary care of the transgender person.
I don't know, it's just me and you.
Yeah. So that was a big part of my advanced practice nurse training. As a registered nurse prior to that, I've been a nurse for about 9 years, and I've worked in critical care and typically acute care settings as manager, things like that. In my role at Proud Family Health, I provide primary care services to people across the lifespan, primarily about 10 years old and up. I do a lot of hormone therapy for transgender people. I provide PrEP services and PEP services, which is pre-exposure and post-exposure prophylaxis for HIV. And I follow CDC guidelines on that, which can be regular follow-ups, and so I see a lot of patients and a lot of people to provide those services, and all under the umbrella of primary care services for many of our patients.
That's wonderful. Thank you both, and again, welcome. So could you, for our audience, would you mind defining the LGBTQIA community? Who are they?
Sure. So we are everyone and anyone. We are in all settings and all places. And it's also important to remember that. But just to go through the breakdown of what it is. So the L is for women who have sex with women, that would be lesbians. G is for men who have sex with men. B is for bisexuals, so either having sex with a male or a female. The T is transgendered, and that's a person who doesn't identify with their assigned sex at birth. And Q, there's actually two Qs, so it could be questioning or queer. So questioning is someone who's still trying to kind of figure out where do they fit, or sometimes they just like to stay within that realm. Queer is a term that we have kind of taken back because it used to be used as derogatory, but we have taken it back and kind of now we own it. So it's can be used in any type of term, however people feel necessary. The I is for intersex, which is for someone who has either different variants of either chromosomal issues or anything like that. So they usually do not typically fall into the male or female gender. So they're somewhere in between or whatever. And then the A can be asexual or ally. So an asexual is someone who sex is not a part of their relationship. It's just a relationship between people, but there's no sexual type of interaction. And then an ally would be anyone who wants to just be a supportive of the LGBT community.
Well, thank you. Explanation. So what is unique about the healthcare needs of the LGBTQIA community? I mean, Jeremy, would you like to field that question?
Yeah. So there are specific health needs within this community, and as Danielle had talked about, this is a very broad community. So we're not talking about any one specific group. We're talking about members of many other groups that we look at. So people across the lifespan, people across the economic spheres, people across the gender spheres, people across racial identities. So people come to us with many different identities, not just within the LGBTQIA circle. So within that, but when we do look at health, the specific health needs of this population, we look at some of the kind of broad categories, and there are some specific screenings and things like that that we do focus on for this population, based on the person's individual activities and things like that. So we look at risk behaviors, and that typically can fall under normal comprehensive primary care for most people. The thing regarding health needs within this community is oftentimes members of the community feel alienated from the healthcare providers. So there's a perceived lack of access for appropriate and trained clinicians. So members of the community may not feel comfortable going to a provider and being out. Right? What does that mean for someone to go to a provider and be out and to sit there talking about, as a patient, talking about all your intimate health details, but then on top of that saying, I am a man who has sex with men, I am, identify as gay, or I'm a woman who has sex with men, or I'm transgender. And that there's a level of potential rejection from the provider, and this does happen, and it's well documented within research and literature that this happens, that people are rejected by their healthcare providers in that setting. And that level of vulnerability for our patients is much greater and can have a much greater detriment to their health. So many of my patients that I see, many of the people that come into Proud have been to other providers throughout the state and have had negative experiences like that. And that may have been 20 years ago. So so there's a large part of the people that I see that like that haven't been to the doctor in many years. So those health screenings, while they may be typical and they may be your standard screening for most people, within this population, it may have been, we may be way outside of the normal or recommended guidelines for those screenings. So when we look at health outcomes and we talk about, or when we look at when people delay care and delay getting or seeking care for health issues, whether it's screening or whether it's for more acute issues, the outcomes are much worse. So for example, someone comes in for, some symptoms that may lead to a diagnosis of cancer, right? The earlier that we detect cancer, the better the outcomes. And that's across pretty much all cancers. So for this population, the risk for negative outcomes in looking at health determinants there's much greater barriers in that way. And so other lifestyle activities that are more specific to this this community, most people think automatically of sex and STDs and things like that, but that isn't completely the risk. So there's mental health concerns, there's risk of depression, anxiety, of suicidal ideation. All of those statistics for the LGBT community at large are much higher, and in some portions of that population can be very significantly higher than the general population. So looking at those issues, tobacco and drug use, substance abuse are higher in different sections of the LGBTQIA community as well. So looking and being cognizant as a provider and addressing those, assessing them, and providing resources and support when it's needed.
Wow.
I think that, yeah.
No, I appreciate that. That was a very broad overview. Thank you so much. So when you initially introduced yourself, you had talked about hormone therapy. So let's talk about hormone replacement therapy. What are the benefits and the risks? What's involved with the monitoring process, and is hormone replacement therapy lifelong for this community?
Yeah, so that's a great question. So the biggest thing that we need to keep in mind when we talk about hormones is what are we treating, right? And I'm going to use that as kind of a very clinical term. What people that are transgender experience is what's called gender dysphoria. And gender dysphoria is the experience, not just the identity of, I'm not transgender, I'm cis male. So that means I was assigned male at birth and I identify as being male. For someone that their identity of their gender does not match the gender that was assigned to them at birth, they experience the distress that they experience from that disequilibrium, or the difference between those, the sex assigned at birth and the gender identity, is called gender dysphoria. So it is a social construct in a lot of ways. It's a real experience for that person. But a person that's transgender doesn't necessarily have gender dysphoria in the theoretical sense. Most people that are seeking hormone therapy, and even those that do seek or don't seek hormone therapy, but what we're treating is the gender dysphoria. So to not just align the person's identity, but to help to ease the distress that the person experiences from having the gender that they were assigned at birth, or the sex that they were assigned at birth, differ from the gender identity that they have. So that is what we're treating in that sense. And I do use these terms in a clinical sense because we're helping people along the process in their life, and we're looking a lot at identity and internal distress that we're helping to ease. So specifically to kind of go in through the process of hormone therapy, it depends on, right, we have two different groups of people if we're looking at a binary group. So transgender people are either transgender male or transgender female if we are looking at binaries. There are some people that fall within the middle that are considered non-binary or gender fluid. Those people may continue to seek out hormone therapy as well, but we may not be treating, or we may not be targeting the same kinds of hormone levels and things like that. Our goals may be a little different, but I'll just focus on more of the binary trans male, trans female kind of approach. So for men. Those are people that were assigned female at birth and now identify as male. The goal is to use testosterone, or the process is to use testosterone to help to have that person undergo masculinization. So a lot of the outward signs that we see from the testosterone is facial hair, the voice will deepen, they'll have increased muscle development, and fat redistribution will change into a more masculine type of body shape. So oftentimes we think of the V shape, wider shoulders, narrower hips. Again, the deeper voice, the facial hair will develop. With that, menstruation will typically stop, which can be another aspect of the dysphoria. People will have very specific dysphorias oftentimes. So some people may come in and they may have specific voice dysphoria. So adding on testosterone, which causes that voice to deepen, can help to target those specific triggers of dysphoria. For people that identify as transgender females, or that would like to have more of a feminization, we use two different medications. One is a testosterone blocker. So these are people that were assigned male at birth and now identify as female. So we're going to block the testosterone that they inherently produce. So with that, we typically use a medication called spironolactone, which is a diuretic. It's an old blood pressure medication that has a pretty significant effect on testosterone production. We can also use finasteride or dutasteride, which are two medications that we currently use for hair loss, and that blocks more of one of the specific portions of the total testosterone. So that's one aspect of it. The other aspect is adding on the female hormones, the estradiol. And both of those combined will significantly treat the internal feelings, the gender dysphoria oftentimes, but it'll also help for feminization. So we'll see breast development, we will see genital changes that can be desired for this person. Skin and hair changes can occur. Facial hair and voice will not change as much. Sometimes people can get some decreased growth of facial hair, but they'll still have coarse dark hair on the face. So then other treatments would be needed at that point. Also for the voice, it will not raise in pitch. So training and things like that, potentially surgery, other non-pharmacologic interventions would be needed for that. So risks for both of them, we often look at, and I'm just going to do a general kind of cardiovascular disease can be a higher risk, certain cancers can be at higher risk, electrolyte abnormalities, liver function tests can be, or liver function can become abnormal with the hormones. People can become infertile on the hormones. So with the monitoring, I do close monitoring for all the risks, the side effects. I see the people that are on the hormones more frequently initially, and then spread it out as we know that they're tolerating the medications okay.
So is the monitoring ongoing?
Yeah, so the monitoring would be ongoing. So initially I see people every about 6 weeks. Once I start, and anytime I change medications. And then after that, if they're stable on the medications for about every 3 months, and once someone's been on the medications for about a year, then I may see them less frequently, like every 6 months or further out. Looking for side effects, looking at, we would do lab analysis, looking at hormone levels, looking at risks for certain specific risks for side effects, for example, like liver function tests and electrolytes, just to make sure that that we're not running into any issues. And also seeing them in the office to make sure that the changes that they're experiencing are within what they would like and that they're happy with, that there's no adverse effects that are happening just that doesn't show up in the lab work, and then also just checking to see if they need any additional resources, whether it's not just the medical side of things, but the psychosocial and the whole picture kind of side of things. So if they need to be followed up more closely with a therapist, or if other underlying anxiety and depression is there and manifests at those times. You know, how do we provide the services overall for the whole person, right? We have a lot of those services.
So, and to clarify, so once somebody goes on hormone replacement therapy, then they're pretty much on this the duration of their life?
So it depends. It's really is an individualized journey. So some people will go on the hormones and have surgeries to remove the organs that produce their innate hormones. So that could either be removal of testicles or removal of the ovaries. At that point, that changes the decision. Right? So if we don't want to leave someone without hormones, depending on their age, because that can affect risks for cardiovascular disease, for bone density, things like that. So we have to continue to monitor that and to address those issues individually. Some people are on hormones for life. Some people are on hormones for a short amount of time. So, and that kind of goes back to what the gender dysphoria triggers are. So there are people that could be just facial hair and the voice dysphoria that are the most significant. And once someone is on testosterone and their voice drops, that may be, for a year or two they're on testosterone, and that may be enough to treat their dysphoria at that time in their lives, so that then they can go off of the testosterone and be happy and feel fulfilled at that point. Does that mean that they'll never go on testosterone again? Not necessarily. It's always an option. So each person's journey is really individualized, and especially when we're not talking about transgender people as far as the binaries of transgender male or female, but when we're looking at the non-binary people that identify that way. So then, what is their goal? And that is a conversation at each visit. How are things going? How do you like the changes? Do we want to move more in one direction or another? And a lot of this is individualized healthcare.
Okay. Thank you.
Yeah.
Explanation. So, we talked a lot about some of the conditions that this community is predisposed to. So specific groups within the LGBTQIA community have higher rates of HIV and sexually transmitted infections. Can you tell us what's new in HIV prevention?
Sure. So what's new is in New Jersey, there's been a really big push to end AIDS, essentially. So right now we have the End AIDS by 2025 campaign that's being pushed, and that includes, one, education surrounding HIV. So making sure that our youth and anyone who's sexually active truly understands what type of barriers to use, and also how HIV is transmitted. The other portion of that is testing, because 1 out of 7 people who have HIV don't even know that they have it. So getting people tested is a big portion of stopping the spread. So if somebody knows that they have it, we can take different preventative measures to ensuring that they're not spreading HIV. Another big part of that is what Jeremy had mentioned earlier, is PrEP, pre-exposure prophylactics, which is a single tab regimen that is taken 1 time a day, a single pill, and it is 93% effective at ensuring that a person who is on it will not get HIV. So that can be if somebody has a partner who is HIV positive and they take this pill consistently, that they will not get HIV. And also for people who are engaging in sexual behaviors that are high risk, if they take PrEP or they get the education, but mostly if they take PrEP, they can basically cover themselves in ensuring that they're not going to get HIV, also with using barrier protection. And throughout the state, there's been a big push for PrEP, and in our office, we offer PrEP. Jeremy and Rich do a really good job of ensuring our patients come in, get their labs every 3 months, and that they have their medication. So yeah.
Well, thank you. one of you or both of you had talked about depression and anxiety being prevalent in this community. So how do you screen for that, and what type of help is available? Forgive me for who said it. Maybe it was Jeremy. I don't know. Who would like to know that?
So as is standard for any kind of primary care setting, we do screening on every person that comes in to be seen. So we do an initial screening. If that's positive, then we would ask several follow-up questions. And if that continues to be positive, or certain symptoms are present that are more concerning, then of course I would address the issues in the visit, talk to the person about what's going on in their lives. And from the primary care setting, I do treat anxiety and depression with medications, and that's within my scope of practice. As far as here being on the campus of RWJ Somerset, we're right next door to the hospital that Proud Family Health is located. The hospital has some really amazing resources in their inpatient units. The emergency room is well equipped handling psychiatric emergencies. So if a person does come into the office that is in an emergency, whether they're suicidal or extremely severely depressed, then a referral to the emergency room, taking the person over to the at Somerset here on site is something that is definitely not improved for patient safety. The hospital is well equipped to handle those types of cases. From a more chronic perspective, we do have community members that we engage with that are LGBT friendly, not community members, but partners within the community, within the mental health community, that we have really good relationships, both from sharing patients, but also with Danielle's work and doing outreach and connecting with providers across the state to make sure that they're LGBT friendly, trained as well, and have experience with the community to ensure that our patients go there and feel comfortable. So those are a lot of the resources that we use for anxiety and depression.
Okay, thank you. So members of the LGBTQ community have lower rates of getting health screenings, such as mammograms. So how are you working to promote greater compliance with screening guidelines?
Yeah. So it's been an amazing benefit being here on campus at RWJ Somerset. The work that we're doing in a primary care setting when I see patients, obviously it's typical screening guidelines based on for our LGBTQIA community for that individual. It's based on the organs that they have. So if someone has breast tissue that's been exposed to estrogen, then they would be potentially at risk for breast cancer. So along those lines, our work, we've also been working with Steeplechase Cancer Center here on site at RWJ Somerset. They've been amazing. They've been leaders in this work that we're doing within more specifically the transgender community, but also the LGBT community as a whole. We've been working with them, with their radiologists and physicians over there and their whole staff for several different aspects of it. One is training for their staff to do to make sure that when our patients and patients of the LGBT community as a whole come in to get those services for such as breast cancer screening, for mammography and ultrasounds, that their staff are trained to handle situations that may, if they didn't have the training, may make them uncomfortable. And that's really what is at the heart of what we do as a whole. So we've focused on hospital-wide, not we as in Danielle and I, but as a hospital and as a system, we focused on training all our staff throughout the hospital, doing more specific trainings for the front-end staff that come into contact with patients directly, to make sure that people aren't misgendered or misnamed, that we're using their preferred pronouns and names. So that's been one aspect of the collaboration that we've had with Steeplechase. The other aspect is that we're working on on getting guidelines that are specific to transgender people, especially with breast cancer. So we're working on, or Steeplechase is working on producing those and publishing those, so that I, as a primary care provider, and other primary care providers in the community, in the state, and around the country have resources to look at and to say, okay, this person that's sitting in front of me, do they need breast cancer screening? Do they need, you know, and what do I do? What's the process of that? You know, for a transgender male that has not had top surgery, that has not had a mastectomy, do they need screening? And that for the provider that hasn't had the exposure or training that I've had, that they may, you know, be really at a loss for what to do. So Steeplechase has been leaders in doing that, in help working with us to produce some guidelines for that. So.
Oh, great. Well, let's talk about Proud Family Health for a moment. So, Danielle, can you tell us a little bit what types of services does Proud Family Health offer?
So Proud Family Health, Jeremy, our provider, he offers primary care services, which includes everything from immunizations to STD testing, your regular annuals, your PAPs, all of that type of stuff. We also do HIV prevention. So that is PrEP, pre-exposure prophylactics, or post-exposure prophylactics, which is PEP. So if an individual has an exposure, they can call us and we will get them in immediately. We also have support groups. So we have the support groups for family and friends, and then we also have the support group, which is ran out of New Brunswick, for transgendered individuals themselves. Am I missing anything? And then we also do referrals, which would be my part, just ensuring that our patients are getting the care that they need and finding the services that they need, ensuring that all resources, whether it's behavioral health or support groups, or it's an orthopedic doctor or anything like that, just ensuring that they have access.
So who else, is anybody else at Proud Family Health, who else plays a part?
Oh, well, we have Rich, our nurse. He is absolutely amazing. He sees every single patient that comes in. Always will see Rich. He also does the education for the shots for individuals who are getting hormone therapy. And then we have Ramel, who has been with Proud since the beginning of Proud. She helped man all the phone calls all by herself in the beginning, and she's wonderful. She does the prior authorization. She is the first line of defense when somebody calls. She's the first happy voice on the phone. And we've recently just got our new staff member, Avery, who is absolutely amazing. We're very happy to have Avery. They are a big part of what we're doing here, and they bring also a different light and a different sense of community to our office. So we have really good staff.
Very good. And, you know, what makes Proud Family Health special? Is it true that we're one of the only or few in the state to offer this type of service?
Yes. I think what's really important about Proud is the leadership that's in the hospital. We have, from the top down, we have full support from the president, from directors, from the vice presidents, and that plays a big part in what we do and what we're able to do. And I think also our staff. I think the people that are involved in our office, we are all in the community. We all do this work out of passion and love for the community. It's not just a job, it's something that we look forward to doing every single day. And I think that kind of sets us apart. So yeah.
Okay. Thank you. I want to give our audience some opportunities to ask some questions at this time. So if you do have questions for Danielle or Jeremy, please log on to the chat feature and you can type in your questions. So again, while we're giving our audience a little time to type in any questions they might have, you both had mentioned throughout our webinar this afternoon, you talked about LGBTQ friendly providers. Could you elaborate, like somebody who's looking for a provider, what are the qualities that they should be looking for, again, to be LGBTQ friendly?
I'll let you go for that.
So for me, it comes down to, do they have policies in place, and also if their staff is truly trained? Because a lot of times I've found myself running to a lot of places that say they're LGBT friendly, but then when I call and I ask their front staff basic questions, they truly don't really understand what that means. And it can also be, as a patient, just asking your provider specific questions to really gauge, do they really understand the needs of what you need? And that's also important, is taking some ownership of that and saying, does my provider truly know? And then also seeking out a provider who displays themselves as truly being LGBT friendly. So they might have something on their website, or they might have something in their office that truly represents that they are LGBT friendly.
So what type of policy would they be looking for? Would somebody be looking for? You mentioned, to be LGBTQ friendly, they have to have policies. But if you're inquiring and making all these inquiries to physicians, what policies should they have in place to make them LGBTQ friendly?
So one thing that I tend to look for is, do you go by the name on ID, or do you go by what I'm telling you I would be preferred to call? So I've actually ran into some offices where they say, our policy in our office is to refer to people as they are on their license. So they will not. So if I came in and I'm saying, I like to go by Danny, I know my ID says Danielle. Do you have something in your policy to say that, okay, we will call you this regardless of however your license says? And that alone is a big factor. And also having policies in place just to ensure that you're able to treat people how they would like to be treated. Not as you would like to be treated, but as they would like to be treated. So if I would rather prefer he pronouns, that you are using my preferred pronouns. And that in your office space also, that the provider is understanding that they're going to treat you, that they're going to take you as a patient, regardless of your sexual identity or your sexual orientation or whatever it may be.
Okay, very good. I know we've talked about preventative screenings and some of the preventative screening guidelines, but can you, maybe Jeremy, share with what are the preventative screenings the LGBT community should have on a routine basis, and how often?
Yeah, so this is no different than any other person in the community. I mean, this is where when, and I've been told this by members of the community, LGBT care is no different than your cisgender or straight care. And it's, in a lot of ways, it's not. So, so specifically for looking at, say, like cervical cancer screening, for breast cancer screening, all of those, or for bone density screening, all of those things are recommended by various organizations throughout the, nationally and internationally, for having different timelines and startings and frequencies. So that doesn't change within the LGBTQIA community. The thing that's different is looking at the health disparities. What are the individual risks for this person based on their behaviors, based on their individual risk factors? Within the transgender community, the exposure to different hormones can change risks. And so taking that into account, and that is, again, a very individualized thing, right? The person that transitioned and started blockers and and hormones at 18 is going to have a very different, you're going to be looking at that person very differently than the person that is 55 and starting them, just because of their exposure to the hormones. And the person that's been on hormones for a year versus someone that's been on it for 10 or 15 years also is going to be very different. So at the heart of it, the one thing that we do is we take an organ inventory, and that's a very like clinical term, and I hate using it, but that is just, it's what we used, and I don't think there's a better term yet that's been created. But what we do is if someone has a cervix, then we want to check for cervical cancer. So if someone's so that's whatever their gender identity is. If they have that organ, if there's screening requirements that are recommended, then we would follow those guidelines as best and as reasonably as we can. If someone has breast tissue, that whether they've had a mastectomy or not, then we need to consider that person to be at a higher risk for, if they've gone through an estrogen-based puberty, then that person's going to be at a higher risk for breast cancer development than someone that hasn't, and so, or doesn't have that tissue or didn't go through that type of puberty. So those are the considerations. So it does change, and it is a conversation that I will have with my patients on an individual basis, looking at what are the recommended guidelines versus gender people, and then how do we apply that individually to this person based on their exposure, their history, all those things. So I'm not really giving you a straight answer, but at the same time, it's so individualized that oftentimes it's just a conversation.
Yeah, thank you very much. We have a question from our audience member. If you can speak to what allies can do to support PROUD in the community. Danielle, would you like to field that one?
Sure. To support PROUD or to support the LGBT community?
As written, it's to support PROUD.
Oh, to support PROUD. Well, you can contact me, and I can definitely, you can definitely.
We have volunteer activities.
Yes.
We have a lot of events. Yes. This is a great month for volunteers.
But other things that you can do is showing up workshops, educating yourself, going to, like Rutgers has a SAFE training, and truly understanding what the LGBT is, what's the difference between sex and gender, and truly understanding that, because then you can be vocal and helping the discrimination that happens within our communities, and having those conversations, because we are a small community. I would like to say that we're everywhere, but essentially we're not. So even when you're in those spaces that we're not, you can help break down those myths and break down those barriers by having those open conversations. But again, if you would like to help out with PROUD, you can definitely contact me. I am at events all over the state, and if you would love to come table with me, come host an event with me, I would absolutely love it.
And if you hear of any providers that are also LGBT friendly, or if you have friends, or if you're a part of the community yourself, any resources, things like that, letting us know so that we can add those people and those providers to provide those resources for our patients, you know, so because even though we are both out and about a lot, at different events, we are having a lot of conversations with members throughout the state within the community. It's also important for us to know those, and sometimes there are people that go under our radar, or organizations, things like that. So so any kind of contact and can really go a long way.
And just to add, if you come across an individual in the LGBT community and you hear them saying, oh man, I wish I had a provider, or man, I wish there was a place for us, just giving them our information is definitely helpful, and people are so thankful.
So how does one reach you? So to help our members out here, you're saying contact me, but how do they contact you? What is your phone number?
So 908-243-8647. That would be our office number. That is our direct line. And then Jeremy's email is JEREMY.PYKE at rwjbh.org. And mine is Danielle, DANIELLE.KING at rwjbh.org. And if we do not pick up the phone immediately, we do answer our calls within the same day. And if you email me, I will definitely reach back out to you.
Great. I know we're a little bit over, and I do apologize to our audience.
Oh, it's fine.
But this has been a wonderful talk, so thank you both.
Thank you.
So this concludes today's webinar. Thank you again for joining us. Thank you, everybody. Just as a friendly reminder, please remember that the opinions shared here today by our medical experts are not a substitute for medical advice from your own physician. If you do need a physician, please call 1-888-724-7123, or as you have shared, Proud Family Health's number. Again, Danielle?
908-243-8647. That's 908-243-8647.
And for more information about Robert Wood Johnson University Hospital Somerset, please visit our website at www.rwjbh.org/Somerset. Thank you all for joining, and have a great day.